Now on to cyanotic disease number 7. Don't worry, we're almost done. Epstein's anomaly. So Epstein's anomaly, what is this anomaly here? Epstein's anomaly means that we usually have a right atrium and a much larger right ventricle. In Epstein's anomaly, the right atrium basically takes over part of the ventricle and leads to a major tricuspid regurgitation also as a result. So this is called quote-unquote atrialization of the right ventricle. So part of the right ventricle becomes part of the atria, and you have a majorly regurgitant tricuspid valve. So let's talk about the pathophysiology. Associated with maternal lithium use during pregnancy. Classic finding. You have an apical lateral displacement of the tricuspid valve leaflets into the right ventricle. So the tricuspid valve, which is normally pretty posterior in the right atrium compared to the right ventricle, moves anteriorly and laterally to go into the right ventricle and atrialize part of it. Remember, everything before the tricuspid valve is the atrium, everything after is the right ventricle. So if the tricuspid valve goes into the right ventricle, more of it is now part of the right atrium now. So let's take a look at an image over here. Notice how small the right ventricle is and how large the right atrium is. And you see this arrow here? It's showing that blood is going backwards from the right ventricle back to the right atrium, which is abnormal. So it leads to atrialization of part of the right ventricle posterior to the valve. So what normally was part of the ventricle is now part of the right atrium. So you get impaired right ventricular function because it's so much smaller and has backflow as well as forward flow. So that impairs the right ventricular function. And you also need an ASD and a PDA to allow for adequate pulmonary blood flow. So say you didn't have an ASD or a PDA, what would happen? Not a lot of blood would go forward because a lot is going to be going backward to this majorly regurgitant valve. And a PDA helps move blood from the aorta to the pulmonary artery to allow for oxygenation. So severity of disease depends on tricuspid regurgitation. The more severe the regurgitation, the less blood goes to the lungs and gets oxygenated. And right ventricular function, because the right ventricle is not pumping, you can't oxygenate the blood in the lungs. So you get cyanosis because the blood has to cross over and mix with the oxygenated blood to go back to the right ventricle, or to bypass the right ventricle through a PDA to get to the lungs. So some signs and symptoms over here. We have cyanosis, which we discussed before, because the blood is shunting from the left to the right and from the right to the left and mixing. As where you get cyanotic blood, and that goes to systemic circulation to the body. Also notice you get decreased right ventricular outflow due to right ventricular dysfunction and atrialization. So because the right ventricle is pumping forward and backward and has to meet the demands of the body by pumping into the lungs, as a result, you get right side overload cardiomegaly because the right side is smaller and dealing with larger amounts and pushing forward and backward. Alright? So you get palpitation and sudden cardiac death. Why? Because the right atrium is so large, it stretches the electrical fibers, and the right ventricle is also damaged, and the fibers are damaged because of the decreased function and decreased muscle mass of the right ventricle, that you can get palpitation and sudden cardiac death because of the damage of the electrical fibers on the right side of the heart. So you get right bundle branch block and Wolff-Parkinson White because of these different electrical abnormalities. You also get right heart failure symptoms plus enlargement. We said so because of the tricuspid regurgitation, the right ventricle is going to be getting larger and larger, trying to pump forward and backward. That's why you can get heart failure. Heart murmurs. Murmurs that you can see are holosystolic murmurs at the left lower sternal border, which is pretty necessary to mix blood between the left side and the left side being oxygenated, the right side not as much. And that's necessary in addition to a PDA to oxygenate the blood flow to the lungs. Another thing is that this murmur may be heard more laterally due to a displaced tricuspid valve leaflet. So the holosystolic murmur can also be heard because of the tricuspid regurgitation. And if you have a tricuspid regurgitation from a more posterior tricuspid valve from a more anterior tricuspid valve leaflet, you will hear it more laterally, meaning you'll hear it more close to the left lower sternal border and closer to the apex on the left side. So, in summary, what that means is, if you have the left lower sternal border, holosystolic murmur, you can think of a tricuspid regurgitation because of how it's more anterolaterally placed. If it was a normal tricuspid valve regurgitation, you'd most likely hear it in the right lower sternal border because of the original location and proper location of the tricuspid valve. Now, we have a loud tricuspid component to first heart sound due to elongated anterior tricuspid leaflet. So, the tricuspid valve, one of the leaflets, is very long and anteriorly placed into the right ventricle, and it takes a lot more time to close, and it's like a sail in the wind. Because it's so much bigger and trying to close, it's going to make a sail sound while it moves through the blood, and that's a classic association with Epstein's anomaly. Let's talk about diagnosis now. So diagnosis, if you see arrhythmias associated with a condition, you should think of Epstein's anomaly, such as right bundle branch block, which is a delay in conduction on the right side, Wolff-Parkinson-White, which is an accessory conduction pathway, which we'll talk about in an arrhythmia section, and supraventricular tachycardia, where the atria beats too quickly, even though it's regular. The difference between SVT and atrial fibrillation is that SVT is regular, AFib is irregular. You also get right atrial enlargement and right axis deviation on EKG. So chest x-ray, the findings on chest x-ray, as you can see right here, the right atrium is super enlarged. Why? Because it's so much bigger and it's taken over the right ventricle. And you also get regurgitant flow causing the right atrium to get bigger. And it also pushes the left ventricle to the side as well. So you get right-sided cardiomegaly, and look how empty the lungs are. Why is that? There's not a lot of pulmonary blood flow because the right ventricle is so atrialized and pumping backwards through the tricuspid regurgitation. So key thing to note right there. Prominent atrial border, as we mentioned right here. An echocardiogram is the best test for diagnosis. Like always, we always want to do an echo for definitive diagnosis, and initially do chest x-ray and EKG for management. Treatment, control the heart failure symptoms. So because this patient is going to have the right side being failing and overloading with blood and having too much tricuspid regurgitant flow, you need to control the heart failure symptoms first before doing any definitive treatment. If you have severe tricuspid regurgitation and lots of cyanosis, you need to do surgery.